instead of the traditional stand-up, we wanted to be more inclusive of the entire staff. You know, we wanted the CNA and the nurse involved in that stand-up that we traditionally had kept behind closed doors.
Our frontline CNAs and floor nurses are the ones that know our residents the best, and if we could figure out how to communicate better with them, then we would better care for our residents. And so it just made sense that we would bring the manager meeting that happened every morning, we would bring the manager meeting to them.
So the way we decided to do that was to what we call standing up together, or kind of huddling together at that 9 o'clock meeting. Instead of behind the doors, we went out into the halls.
When we first started the interdisciplinary rounds on the units, we kind of followed the format that we did in the morning meetings, which we would go through the 24-hour reports from the day before. So we reviewed every resident. So we started with that format.
The nurse would read the 24-hour report, go over the risks and opportunities.
But it was important to kind of have a format to follow. Sometimes in meetings people can get off track, and so following that 24-hour report, keeping people on track with just talking about the resident care needs is how we started. And then we also reviewed the orders that have come through for the past 24 hours. We were debated initially as to how often we should do it. We talked about every day and felt like that was too much. We talked about once a week, and then kind of fell upon twice a week, and I think that is for us the right number. I really felt it was important that the staff nurse be the one to give report, because that's her residence and she has ownership over her residents and her staff. But some of them, I knew it was a little intimidating to give a report in front of the DON and the administrator and the social worker and all these people. And so knowing people's personalities, those that I knew felt more comfortable took right to it, others that were more quiet, I initially started giving the report, and then slowly kind of got them more involved in it until they had a comfort level in giving the report. And so that took, a couple months really of that process. Now all the nurses give the report and they don't seem to have any problems with it. They feel comfortable.
And then the CNA would also kind of chime in about, well, Mrs. Jones doesn't have the right type of wheelchair, or Mrs. Jones has a walker that doesn't fit.
Because at first they were very quiet, but when someone would offer an idea, to say, thank you, that is a great idea, and giving that positive reinforcement. Now they are very comfortable. The other day somebody said, I want to interject, and I loved it. It was a great moment. So
we incorporated everyone from those stand-up meetings, the administrator, the DON, the CNA from the hallway, the social service director, the dietitian, and so we had all the constituents right there, and so they could get an answer immediately.
Really the whole goal of the meeting originally was to support the CNAs and to get more information from them about how to care for the residents, because they know what the residents need more than any of us.
We've always been good at supporting frontline staff, but this gives us an opportunity to show them that over and over again, like they can count on it. We're gonna be there to hear anything that they have to say. That's always true, but it's clearer when it's something that's anticipated and something that they can count on.
Might have been somebody was, we got in somebody last night from the hospital, but he was 6'7", and the bed didn't fit. Well, the CNAs were like, that bed does not fit, that's going to be a problem. And I was there, and I could say, let's get a bed, make sure that this gentleman has a bed that fits him. And so it was immediate, instead of waiting a couple of days before you found out, oh my gosh, he's not fitting in that bed, or the wheelchair isn't right.
So we want the CNAs to be at the meeting. At first, it was hard to get people to come to the meetings. We'd all be at the meetings, and the nurse and the CNAs would not be there, and I'd go to get the CNAs, and they say, well, I'm right in the middle of, this call light just went off. I have to take care of this resident. So we found it best to have somebody ready, available to answer the call lights, to jump in. So I would, jump in. So you go ahead and go to the meeting. I'll take care of this issue that you're dealing with right now. And we always had somebody available. One of the managers would jump out of the meeting if a call light went off to take care of that, so that the CNAs and the nurse could be there and not feel like they had to leave the meeting. Since we've been doing it for quite a while now, it's not as much of an issue. I know that staff organizes their day a little better. They know it's coming. Call lights aren't going off during the meeting. So I feel like it's important. They know it's important to them to be there. They have input. They know it's their opportunity to say, hey, something we need for a resident or a concern about a resident, and things can happen very quickly. And so I'm finding like the call lights are just not going off when we're doing these meetings, and I think it's because they're planning that they're going to be there and they're getting everything taken care of so they can be there.
We were able to respond to things immediately.
As time went by, we came up with some ideas that everyone's here, the social workers here, management's here. If there's behavioral issues that we need to address and talk about, it's a perfect opportunity. So we started including more about behaviors that had come up and what kind of things we could care plan and change, and had a whole discussion with the nurses and the CNAs and the social worker, the whole team, the right people that had the information to make those adjustments. Then I thought, I was having a nutrition meeting one time with the dietitian and the ADON, and I thought, why aren't we doing this in the meeting? So we invited her to come to the meetings, and now we do the nutrition meetings also on the units. It doesn't really take that long. You might think that it would take long, but it doesn't. She knows the problems, the staff know the problems. They discuss what needs to happen right there, and we go through anybody who's at nutrition risk or having a weight loss or problems, and discuss ideas and what we can do to promote them eating better, what kind of foods they like. We work through that right on the unit. And so then I thought, okay, wounds. Let's add the wounds. So the wound nurse, she talks about everybody that has the wound, anybody who's had a change in condition that might be at risk, what new interventions we are implementing, and we go through that as well now. And for the future, I think, we can add other things. The MDS week that they're in, talking about the ARD period. We always talk about anybody that's fallen and new interventions that we could try. I just think there's a lot of possibilities with what we can do with this meeting. We did have a resident who, we were talking about the fact that they have a UTI, and I said, well, let's get the care plan going right now. Right when we were in the meeting, we did it. I knew it was done. Instantaneously, without a lot of time and effort. You could do the care plan right during the meeting.
We were a little concerned about HIPAA, but we overcame those initial misgivings about some of that.
So about 10 to 12 people on each unit are involved in the meeting, and we do try to find a private space. Sometimes we cram into a small office. We
tried to keep it short. We tried to keep keep it moving, and even to this day, it's only probably about 10 minutes long on each hallway.
We started Tuesdays and Fridays, meeting with them and moving from the memory care center to our long-term care unit to the rehab unit.
Sometimes in meetings, in long-term care, it can be kind of a bash the nursing department meeting, or the last shift didn't do this right or that right, and I wanted to keep it a positive format. I didn't want it to turn into just negativity on everything that's going wrong. I really wanted it to be about the resident care and what we can do to make that better. So we had a couple instances where, CNA, really the night shift didn't do this or didn't do that, and after the meeting, I just pulled her aside and I said, if you have concerns or comments, I want to know what they are. I want to talk to you about that, but that's not what this meeting is for. This meeting is to talk about resident care issues. Another time we had a CNA who, I think she was really frustrated with a resident and their behavior, and had some kind of negative things to say about the resident, and I just felt it was a little bit inappropriate in the meeting. So after the meeting, I just pulled her aside and I said, I can tell you're frustrated. Let's talk about that. This meeting's not the format for that, but I'm always here to talk to you and help you with your frustrations. And so we just kind of handled those things that way.
And so we started to do that twice a week instead of our morning meeting with the therapy department, the social services director, the DON, the ADON, the billing, and our administrator, all these folks that had been meeting. we brought them to the CNAs and the nurses on the floor, on the units, closer to the residents, and just started to hear more about who the residents were, what quirks that they might have, what things that we could do differently in our care to just care for them better.
You know, the little details, like how hard is it to communicate to all your staff that a lady wants only Puffs Kleenex and she wants them on the right side of her bed. As a DON, it's really, I've found, it's, you know what, on Tuesdays, instead of coming out of the meeting more stressed or feeling like it's a time killer, you know what, I've gone around, I've talked to every staff member first thing in the morning, I've found out what all the issues are. Half of the things have been immediately taken care of because everybody's there that needs to know. If we need a new wheelchair, therapy's there. Can you evaluate their wheelchair? We need a new wheelchair. The administrator's there. If we need some over-the-bed tables, he takes care of it. Everything happens so immediately. When I get done with a meeting, sometimes I'm like, this is cool. I can actually go do some other work right now.